Okay, hi Tabitha. Okay, we're just getting started in the right knee. We're looking in the medial compartment. You can see our shaver spinning there. It has suction attached to it. This allows us to irrigate the knee with some normal saline or salt water. We can see as we look above that you've got some arthritis on the femoral condyle, right? You can see how this little cartilage flap is a little bit loose there. Okay, so anything that's clearly loose, which usually means it comes to the shaver with suction, we can debride here. And now we're going to hold the camera there for a minute, please. We're going to hold tight, two hands. We're going to look at that, because I'm going to straighten the knee a little bit. We're going to look at this meniscus. And there's the degenerative tear in the meniscus back here. So we'll start the shaver. You can see how it's split. And you can see these little deposits in the meniscus, which we talked about in the office, as a sign of meniscal degeneration. And so already it's starting to look a little bit better. We'll take a biter, curved up, and show you how we get to this posterior horn. Open my outflow on the, I got it. And after we trim this meniscus, we're going to put our shaver back in. We'll show you some more in a little bit. Okay, we're done in the medial compartment. I think we've taken away all the bad meniscus back to a stable rim. You can see how it looks there. You've got some arthritis, which is why we're also combining this with our biologic bone marrow concentrate procedure today. And now we're going to look at your old ACL reconstruction. This is it here. It actually looks pretty good. That actually looks pretty good in terms of the ligament. Your knee was stable, and we can see why. That ligament, that graft that you had is still there, still working. And next we're going to look in the lateral compartment. Okay, so here's a good picture of this meniscal pathology. It's kind of chondrocalcinosis. And again, this meniscus ends up tearing a lot more often. I don't want to take away anything that we don't have to. Push down on the knee. And as we look here, that's really all I want to take. We're going to put in our shaver next. Okay, so now we've got our shaver in, just kind of fine-tuning things here. You can see you've lost some cartilage on the tibial plateau down below. We're just making sure we get this posterior horn. Okay, and that looks about as good as we're going to get it here. Okay. Okay, and finally, this is the patella and the patellofemoral joint. Fair amount of arthritis here too, as we see. We can track this all the way down the front of the knee, all the way down to here. Okay, so other than some synovitis, which is what I'm working on here, I'm going to stop before we get into anything that's really vascular. Other than that, what we're seeing is that the patellofemoral joint has a fair amount of arthritis in it. The trochlea here, which is what we're looking at, has a central area that's not normal anymore. You can see it's kind of rough, these edges. Again, I don't want to remove anything that's stable, but we'll just do the best we can here. Okay. And as we look over here a little bit, we're just getting a pretty good idea of how much of this central part of the femur, the distal femur, is involved here. And as we look up at the patella itself, your kneecap, we can see some areas here that are a little bit rough. Okay, and so now we're going to, close to being done here. We're going to irrigate out. This is the suprapatellar recess. This is the area that we often inject, especially when we're not in the operating room. We inject with ultrasound guidance. Let's see if I can get this to clear up a little bit for us. So coming in from the lateral side would be right over here, and we'll show you what that looks like in just a minute. Okay, so here you can see we're looking from the lateral parapatellar portal, and if you look at the ultrasound image, you can see the black fluid, and you can see what it looks like here. This is obviously more of a fusion than we normally see. When we put the needle in here, you can see the needle coming down there. I'm going to try and show you on our screen what it looks like. Okay. And now let's see if we can find that arthroscopically. Okay, so there's our needle arthroscopically, and on the ultrasound image, at the same time, you can see it there. Okay, so needle on the ultrasound, needle arthroscopically. Now as I bring it down close to the patella, but anyway, that's a pretty good image. You can see the needle tip there. And now watch, can you hold the transducer very still? If you watch as I turn off the pump, and the fluid starts to go down, and you look at the ultrasound image, which we're not seeing yet. There, okay. Hold right there. So So I need to record the ultrasound. You know what? Can you grab my camera, please? On top of that thing. Just hit, let me see, is it set? Yeah, hit record, and I need to record that. I need to record that. This will be better. Okay, tell me when you're going. Okay, good. So there, I just want to show you an example of the needle. You can see it on arthroscopically. You can see how it's in. You can see some of the dangers where you could go down into this pad. Okay. Or if we go too superficial, you can see what happens here. We get up into this fat pad. We don't want to do that. And so now as we keep it right here, I'm going to take some of the fluid out. Okay, now basically all the fluid's out. There's our needle. You can see how much more difficult it is to see when there's not much effusion. There's just that little bit of area right there. We aim for that clear spot. It's hard to see arthroscopically anymore, but we know we're inside the suprapatellar space. So we're going to inject our bone marrow concentrate there. Good luck to you now. Bye-bye.